Hello and welcome to this session. In this session, we are looking at genetic disorders. This is one of the high human pathology topics, and it is one of our fifth lecture on the main six lectures related to human pathology. So here we are going to use this one as our outline. We'll be able to give an introduction to genetics, look at mutations, describe the single gene disorders, multifactorial inheritance, normal karyotype, and psychogenetics. Then look at selected genetic disorders or diseases, and finally look at some of the review questions. So, on introduction to genetics, genetics is the branch of biology that normally deals with heredity, especially the mechanism of hereditary transmission and the variation of inherited characteristics among similar or related organisms. A gene is a molecular unit of heredity of living things, and genes are normally stretches of DNA and RNA that code for a polypeptide or for an RNA chain that has a function in the organisms. So living things will depend on genes as they specify all proteins and functional RNA chains. So genes do hold information to build and to maintain an organism's cells and pass these genetic traits to offsprings. Some organelles, for example, the mitochondria, are self-replicating and are not coded by the organism's DNA. Right. So all organisms have genes corresponding to the various biological traits, some of which are immediately visible, such as the eye color, the number of limbs, the complexion, the hair texture, some of which are also not cannot be seen by our eyes, like the blood type or increased risk for specific diseases or thousands of basic biochemical processes that comprise of life. So, when looking at these genetic disorders, it's important for us to understand what the DNA and the RNA is. And this is just a repetition of what we had covered before. We say that the DNA is a deoxyribonucleic acid that is usually abbreviated as DNA, and it's the molecule that carries genetic information for the development and functioning of an organism. DNA is normally made up of two linked strands that normally wind around each other to resemble a twisted ladder. So it is normally referred to as a shape known as a double helix form. It's a double-stranded helical structure, and it's made up of nucleotides. So each nucleotide consists of five carbose sugar. That is what you refer as the deoxyribose, followed by a nitrogen containing base attached to a sugar, and finally a phosphate group. We have four different types of nucleotides that are found in the DNA, which normally differ only in the nitrogenous base. The four nucleotide bases are given one letter abbreviation as a shorthand for the four bases. So we have A for the adenine, G for guanine, C for cytosine, and T for thymine. If you try to classify all this one, you find that the adenine and guanine, AG, abbreviated as AG, these are usually purines, whereas cytosine and thymine, CT, are the pyrimidines. If you look at our structure on our right, we have the chromosome here that can that forms the DNA. You can see the DNA. Okay, so and then gene is normally a section of the DNA. If we try to get it here on our left, we can be able to appreciate the sugar phosphate backbone, the base pairs. Okay, so that we say that G pairs with C, and C pairs with G, T with A, and A, T, and we are able to see the nitrogenous bases. So we have some differences between the DNA and the RNA. Okay, in terms of the sugar in the backbone, you find that the DNA has the deoxyribose sugar, whereas the RNA has a ribose. In terms of the bases, we have the adenine, thymine, cytosine, and guanine. Whereas on the RNA, we'll be having adenine, same as the DNA, but we have uracil instead of thymine. and cytosine and guanine remain. In terms of base pairing, we have adenine pairs with thymine, whereas cytosine pairs with guanine. On the RNA, you find that the uracil and cytosine will pair with the guanine. Okay, in terms of whether it's double-stranded or single-stranded, of course, we have already said the DNA is double-stranded, while the RNA is mostly single-stranded. Helical structure is, it's there in the DNA, but it's not there in the RNA. Okay, usually forms secondary structures if you insist. The functions of the DNA is to store genetic information, while the function of the RNA is to transmit genetic information and is involved in protein synthesis, enzyme functions, and many functions. In terms of where it's located, you find that the DNA is located in the cell nucleus and the mitochondria in most eukaryotes, throughout the cell in the prokaryotes, while the RNA is found in the nucleus, cytoplasm, and ribosomes. Alright, in terms of type, DNA is present as one type in cells, though there are different forms like mitochondrial DNA. But when you look at the RNA, we have several types, including messenger RNA, transfer RNA, and ribosomal RNA. In terms of role in protein synthesis, the DNA provides a template for a messenger RNA synthesis during transcription, whereas RNA carries this genetic information from the DNA to the ribosomes and serves as a template for protein synthesis during translation. So the DNA is composed of the deoxyribonucleic sugars and a phosphate, while the RNA will be composing of the ribose sugar and the phosphate. DNA is stable under alkaline conditions, okay, while RNA is less stable and more prone to hydrolysis under alkaline conditions. Lastly, we have the DNA. Okay, you find that replication involves DNA polymerase, while the transcription involves RNA polymerase for the RNA. Okay, so RNA is a ribonucleic acid, and it consists long, usually single-stranded chain of alternating phosphate and ribose units with bases including the adenine, guanine, cytosine, and uracil bonded to the ribose. So RNA molecules are involved in protein synthesis and sometimes in the transmission of genetic information. The basic components of RNA are the same as the DNA, with two major differences. Mainly, when you look at the pyrimidine base, uracil will replace the thymine, and the ribose will replace the deoxyribose. So adenine and uracil are formed by two hydrogen bonds. The mechanism of cellular and tissue dysfunction in genetic diseases are viewed as organs they affect. To some extent, you find that these mechanisms are similar to those that occur in non-heritable disorders. So we have classification of genetic diseases, and we say that they are broadly classified into three groups: those that are genetically determined. We also have those diseases that are almost entirely environmentally determined, and look at now the combination for number three, those that can to which both nature and nurture contribute. Okay. So, however, progress in understanding molecular basis of these many so-called environmental disorders tends to blur this distinction. At one point, you find microbial infections are cited as examples of disorders arising wholly from environmental influences. But it's now known that individuals' genetic makeup considerably influences his or her immune response and susceptibility to microbial infections. In fact, the genetic contribution, even in more common diseases, is far greater than it's commonly appreciated. Surveys have indicated that about 20% of pediatric inpatients in university hospitals in USA suffer from the disorders of genetic information. This data describes only the tip of the iceberg. When you look at the chromosomal aberrations, they have identified as many as 50% of spontaneous abortions during the first trimester and many more probably had gene mutations. Only those mutations compatible with independent existence constitute the reservoir of genetic disease in the population at large. Several pediatric disorders are of genetic origin. However, it must be borne in mind that not all genetic disorders are present in infancy and childhood, and conversely, many pediatric diseases are not of genetic origin. To the latter category belong to diseases resulting from immaturity of organ system. In this context, it is very helpful for us to clarify some of the three terms that are commonly used in diseases. The terms include hereditary, familial, congenital. You find that congenital hereditary disorders are derived from one parent and are transmitted in gametes through the generations and therefore are familial. The term congenital simply implies present at birth. It should be noted that some congenital diseases are not genetic. For example, congenital syphilis. Okay. On the other hand, not all genetic diseases are congenital, like the expression of Huntington disease, which, for example, will begin only after the third or fourth decade of life. So that should be the difference. Hereditary conditions are directly inherited from one or both parents due to specific gene mutations, while familial conditions occur more frequently within a family but might not have a clear genetic basis. Familial conditions can occur from shared lifestyle choices or environmental exposures within a family. Hereditary conditions are inherited from parents through genetic mutations, whereas congenital conditions are present at or before birth and can result from genetic, chromosomal, or environmental factors. Remember, not all congenital conditions are hereditary. Familial conditions are observed to cluster within families, but have not have a clear genetic basis, whereas congenital conditions are present at birth and can result from genetic, chromosomal, or environmental factors. Remember, familial conditions can be present in the multiple generations of a family, while genetic conditions are present from the beginning of family. Okay? So let's look at mutations. And the term mutation refers to permanent changes in the DNA. They do affect germ cells and are transmitted to the offsprings and may give rise to inherited diseases. You find that mutations in somatic cells are not transmitted to the children, but are very important in the causation of cancer and some congenital malformation. So details of specific mutations and their effects will be discussed along with the relevant disorders throughout this text. When you look at types of mutations, we have point mutations, insertion mutations, deletion mutation, duplication, substitution, inversion, translocation, and the nonsense mutation, silent mutation, and splice site mutation. So the point mutation, they do change a single nucleotide base in the DNA sequence. So as a result, it may result in amino acid change or no change, which is what we commonly refer to as silent mutation. For example, if you have original codon of CAG, okay, this is glutamine, CAG. The mutation could change to CCG, okay, where the A in the mid has changed from A to C. So this is change from glutamine to proline, and that brings about a change. What about insertion? You find that insertion, it could be addition of one or more nucleotide bases into a DNA sequence so that it shifts the reading frame leading to different amino acids in the protein. Okay, for example, if you had a codon of ATG and the mutation makes it to have ATG where C is inserted between T and C, you see, this becomes a framework shift. It alters the downstream amino acids. What about deletion? Deletion, this is the removal of one or more nucleotide bases from the DNA sequence. This one shifts the reading frame, leading to different amino acids in the protein. Original could be TSC, and we have a mutation now, we have TC, so A has been deleted. It is a frame shift change, all right. Or duplication, where there is replication of a DNA segment resulting in multiple copies of the same sequence. This may lead to gene amplifications and altered protein expression levels. For example, you had AGT, it mutates to form ATG. Duplication repeats the sequence, guys. Substitution is the replacement of one nucleotide with another in the DNA sequence, which may or may not result in amino acid change in the protein. Like originally, we could have GCT and then it mutates to ACG. Remember, this is changed from alanine to threonine, okay? And this is a missense mutation. We could also have inversion, where we have reversal of the orientation of a segment of a DNA within a chromosome, which eventually alters the gene expression pattern and can disrupt gene function. Like, for example, you could be having ABCDE, mutation results into EDCBA. So we have reversal sequence, it reverses the sequence. We could also have translocation, whereby there is a movement of a segment of a DNA from one chromosome to another, which could lead to gene fusion, altering gene regulation and protein function. We could have chromosome 1, ABCD, and chromosome 2, EFG. The result, we're having ABD, EFGH. So we have the translocation of mutation there. We have the nonsense mutation, where a point mutation introduces a premature stop codon, leading to a truncated protein. It results in shorter or usually non-functional protein. Like the original one was AAU, which is asparagine. Mutation occurs, and then you have UAA, which is a stop codon. So once this one is done, it leads to premature, okay, premature stop. Okay, we also have silent mutation, where is a point mutation that does not result in change in amino acid sequence. So no change in the resulting protein sequence. So like we had proline, which is CCC, it mutates to form CCG, which is still proline. All right. Lastly, we have splice site mutation. These are mutations that affects the introns and exon junctions, leading to incorrect RNA splicing. This one normally alters the messenger RNA processing and can result in non-functional proteins. Consider having an example of AGGT, and then the mutation we have AGAT. Okay, so we have disruption of the splicing site. So these are some of the types of mutations that we will be having. Remember, when you're looking at this category of genetic disorders, we'll be having those ones that will be related to mutant genes of a large effect, or diseases with multifactorial or polygenic inheritance. We also have those arising from chromosomal aberrations. So the first category sometimes is referred to as Mendelian disorders, and this one includes many uncommon conditions such as storage diseases and inborn errors of metabolism, all resulting from single gene mutation of a larger effect. Most of these conditions are hereditary and familial, while the diseases with multifactorial inheritance, okay, they are common in humans and they could include hypertension, diabetes mellitus. We say they are multifactorial or polygenic inheritance, which implies that both genetic and environmental influences do play a role in the expression of the phenotypic characteristics of that disease. Lastly, we have those that arise from chromosomal aberrations. This category includes disorders that are the consequences of numeric or structural abnormalities in the chromosomes. So we have single gene disorders, and we also refer to them as single gene defects or mutation, which follow the well-known Mendelian patterns of inheritance. Thus, this condition may produce often called as Mendelian disorders. So, although individually each is rare, altogether they account for about 1% of all adult admission to hospitals and about 8 to 6 to 8% of all pediatric hospital admissions. Mutations involving single gene follow one of the three patterns of inheritance, which could be autosomal dominant, autosomal recessive, or the X-link. Remember, a single gene mutation may lead to many phenotypic effects, which we'll refer to as pleiotropy, and conversely mutation at several genetic loci, which may produce the same trait, that is genetic heterogeneity. All right. Okay, so examples of disorders caused by single gene mutation, we have those ones that are autosomal dominant, like the Huntington disease, polycystic kidney disease, the Marfan syndrome, while the autosomal recessive, we have sickle cell anemia, cystic fibrosis, and phenylketonuria. Okay, then lastly, we have the X-linked. You have the Duchenne muscular dystrophy and hemophilia. Okay guys, for the purposes of our lesson, we need to be able to explain at least three, which is sickle cell disease, hemophilia, and polycystic kidney disease. All right, so let's look at sickle cell anemia. And sickle cell anemia is a hereditary blood disorder characterized by abnormal crescent-shaped red blood cells known as sickle cells. So these cells have a tendency to become rigid and sticky, leading to blockages in small blood vessels, impaired blood flow, and various complications. The pathophysiology of this sickle cell anemia normally involves a cascade of events that is triggered by the presence of an abnormal hemoglobin, referred to as hemoglobin S, within the red blood cells. So this follows this sequence where number one, we have the hemoglobin S formation. We find that sickle cell anemia is caused by these point mutations in the HBB gene, leading to the production of abnormal hemoglobin known as hemoglobin S. You find that this mutation will cause a substitution of the valine for glutamic acid in the beta globin chain of the hemoglobin. So V4G. Okay, all right. So the next step, we have the polymerization of hemoglobin S. So with oxygen levels in blood decreasing, the hemoglobin S molecule tend to polymerize and form long insoluble fibers within the red blood cells. This polymerization is a key event in the sickling process. From there, we go to the deformation and sickling of the red blood cells. So polymerized HBS or hemoglobin S will cause the red blood cells to lose their normal flexible bioconcave shape and become rigid and sickle shaped. So these sickled cells are less deformable and can obstruct small blood vessels. What about impaired blood flow and ischemia? That is point number four. You find that these sickled shaped red blood cells block blood flow in small vessels, leading to tissue ischemia. Okay, this is just lack of oxygen supply and organ damage. So this blockage can cause pain, especially in areas with poor blood flow, such as the bone and the joints. That leads to number six, which is hemolysis and anemia. So these sickled cells are very fragile and they are prone to breaking apart, leading to hemolysis, which is thus the destruction of RBCs. So this chronic hemolysis results into anemia, a condition characterized by shortage of erythrocytes, causing pain, paleness, and shortness of breath. Then we have the inflammatory response and vaso-occlusion. The blockage of blood vessels by these sickled cells triggers an inflammatory response, attracting white blood cells to the site. So this further exacerbates the obstruction, leading to vaso-occlusive crisis. These crises are painful episodes caused by sudden blockage of blood to organs and tissues. So this leads to endothelial dysfunction and damage and organ damage. So these sickled cells will adhere to the endothelial lining of blood vessels, leading to endothelial dysfunction. Chronic inflammation and repeated vaso-occlusion can lead to organ damage over time. Commonly affected organs will include the spleen, the liver, the kidney, and the lungs. Lastly, we have increased susceptibility to infection. Sickle cell anemia impairs the spleen's ability to filter out certain bacteria, making individuals with this sickle cell anemia more susceptible to infections, especially those caused by encapsulated bacteria. So, management of sickle cell anemia will involve symptom relief, prevention of complications, and supportive care. This can include pain management, hydration, blood transfusions, in some cases, bone marrow or stem cell transplantation. There's ongoing research to explore the potential therapies, including gene therapy and novel medications to improve the quality of life for individuals living with sickle cell anemia. The second condition is hemophilia, and hemophilia is a genetic disorder characterized by deficiency or abnormality of clotting factors in blood, which normally leads to prolonged excessive bleeding, even from minor injuries. And there are two most common types of hemophilia. We have hemophilia type A and hemophilia type B, which is caused by deficiencies in clotting factors 8 and 9 respectively. So both types are inherited as X-linked recessive disorders, meaning that they primarily affect males. So what about the pathogenesis of hemophilia? We talk about the normal blood clotting process. Is when a blood vessel is injured, a series of reactions occur to form a blood clot, preventing excessive bleeding. This process involves clotting factors, including factor 8 and factor 9. So for hemophilia type A, these are caused by deficiency or a defect in clotting factor 8, which is a crucial protein for clotting cascade. So without this functional factor 8, the clotting process is impaired, leading to prolonged bleeding, even from minor injuries. As for hemophilia type B, this is also known as the Christmas disease, and it is caused by a deficiency or a defect in clotting factor 9. Similarly, the absence of this functional factor 9 will hamper the normal blood clotting, causing prolonged bleeding. So let's look at chromosomal alterations. And chromosomal alteration, here we have the X-linked recessive inheritance, where we have hemophilia type N and B. These are inherited as sex-linked recessive disorders. And the genes responsible for producing factor 8 and factor 9 are located on the X chromosomes. So males have 1 chromosome and 1 Y chromosome. So if they inherit a faulty X chromosome from the carrier mother, they will develop this hemophilia. In females with XX, they have 1 healthy X chromosome, typically compensates for this faulty gene, making them just to be carriers without having severe symptoms. So let's talk about these mutations in this hemophilia. So hemophilia arises from mutations in the factor 8 gene for hemophilia type A and factor 9 gene for hemophilia type B. This mutation can result in a variety of abnormalities, including deletions, insertions, point mutations, or splice site mutations. These mutations affect the production structure or the functions of the clotting factor 8 or 9, leading to reduced or non-functional proteins in affected individuals. So what about random mutations and sporadic in hemophilia? You find that in some cases hemophilia can occur due to spontaneous mutation that arise during fetal development, what we refer to as de novo mutations. These individuals may not have a family history of this disorder, but the condition is referred to as a sporadic case. For the carrier status in females, they have one normal X chromosomes and one X chromosomes carrying a mutated gene. They are typically asymptomatic but can pass this faulty gene to their offspring. So we need to do carrier testing so as to help identify females that carry this mutated gene, allowing for genetic counseling and informed family decisions. The last conditions under this case, remember we were supposed to look at sickle cell anemia, hemophilia, and lastly, polycystic kidney disease, which refers to a group of genetic disorders characterized by development of fluid-filled cysts in the kidney. The two most common types of polycystic kidney disease are autosomal dominant polycystic kidney disease and autosomal recessive polycystic kidney disease. Let's look at pathogenesis of this polycystic kidney disease, starting with autosomal dominant. Autosomal dominant polycystic kidney disease is caused by mutation in either the PKD1 gene, which is normally located on chromosome 16, or the PKD gene, which is located on chromosome number 4. So mutations in PKD1 gene account for the majority of the cases. The normal functioning of the PKD and PK2 proteins, that is the polycystin 1 and polycystin 2 respectively, is essential for regulating cell growth and differentiation, maintaining the structure of kidney tubules and promoting normal kidney development. So mutation in these genes normally leads to abnormal cell proliferation, fluid secretions, and tubular structure, resulting into formation of numerous cysts within the kidney. So this is gradually enlarged, replacing normal kidney tissue and disrupt the normal kidney function. What about the autosomal recessive? Okay, so for the autosomal recessive polycystic kidney disease, it's caused by mutation in the PKD gene located on chromosome number 6. So this gene provides instruction for making a protein known as fibrocystin. So fibrocystin plays a role in the structure of the renal tubules and the formation of bile ducts in the kidney. So mutations in this gene will disrupt this process, leading to the formation of cysts in the kidneys and the liver. So, autosomal recessive polycystic kidney disease is typically more severe in infants and children, often causing the kidney and the liver failure in life. What are the chromosomal alterations for this polycystic kidney disease? As for the autosomal dominant, this disease-causing mutation are inherited in an autosomal dominant pattern, meaning that the child has 50% chance of inheriting this mutated gene from the affected parent. Mutations in this PKD1 gene are associated with more severe form of the disease, often leading to earlier onset and faster progression of cyst development compared to mutation in the PK2 gene. As for the autosomal recessive polycystic kidney disease, it's inherited in an autosomal recessive pattern, meaning that both parents must carry a copy of this mutated gene for their child to be affected. So in both parents, in both cases, you find that parents are carriers, could have heterozygous for the mutation. So there is a 25% chance that with each pregnancy that their child will have autosomal recessive polycystic kidney disease, and also a 50% chance that the child will be a carrier, and a 25% that the child will inherit neither copy of the mutated gene. All right, okay? Correct. So next we look at multifactorial inheritance. Multifactorial is also referred to as polygenic inheritance. and it's involved in many physiological traits of the humans. It could be the height, it could be the weight, it could be the blood pressure, it could be the hair color, and so on and so forth. So the multifactorial physiology or pathological trait may be defined as one governed by addictive effect of two or more genes of small effect conditioned by the environmental non-genetic influences. It's good to know that even in monozygous twins, okay, even monozygous twins rarely separate. They may achieve also different heights because of these nutritional and environmental influences, okay? And that is very, very key. So when you look at disorders of multifactorial inheritance, a disorder manifests only when a certain number of effector genes as well as conditioning environmental influences are involved. So the threshold effect also explains why parents of a child with a polygenic disorder may themselves be normal. Okay, once the threshold value is exceeded, the severity of the disease is directly proportional to the number and the degree of influence of these pathologic genes. So the following features characterize multifactorial inheritance. So these have to be established for multifactorial inheritance of congenital malformation and in all likelihood obtained for other multifactorial diseases. Find that a multifactorial disorder may occur based on the number of mutant genes inherited. So if the risk is therefore greater in siblings of persons having severe expressions of the disorder, find that the rate of recurrence of this disorder is the same for all first degree relatives. So this could be the parents, could be the siblings, and could be the offsprings of these affected individuals. Thus, if the parents have had one affected child, the risk that the next child will be affected is between 2 and 7%. So the likelihood that identical twins will both be affected is significantly less than 100, but is much greater, 20 to 40, to 20 to 40, okay, than the chance that non-identical twins will be both affected. So in pregnancy, when one child is affected, there is a higher chance, as 7% chance, that this next child will be affected. But after two affected siblings, the risk rises to about 9%. So this form of inheritance underline common diseases. And this disease could include the DM, diabetes mellitus, hypertension, gout, schizophrenia, bipolar disorder, and certain forms of congenital heart diseases, as well as some skeletal abnormalities. Hypertension does provide an excellent example of multifactorial inheritance. At some arbitrary level of blood pressure, hypertension is said to exist because the pressure above this level are associated with significant disadvantage to the individual. So guys, we have cytogenetic disorders and normal karyotype. Remember, cytogenetics is a branch of genetics that is concerned with the study of structure and function of cell, especially the chromosomes. It includes this routine analysis of the G-banded chromosomes, other cytogenic banding techniques, as well as molecular cytogenetics such as the FISH, as well as the comparative genetic hybridization, the CGH. It is estimated that approximately 1 of 200 newborn infants have some form of chromosomal abnormality. The figure is much higher in fetus that do not survive to term. It is estimated that in 50% first trimester abortions, the fetus has a chromosomal abnormality. So, cytogenetic disorders may result from alteration in number or the structure of chromosomes or may affect autosomes or sex chromosomes, while karyotyping is a basic tool of the cytogenetists. So, karyotyping is the number and appearance of chromosomes in the nucleus of eukaryotic cells. This term is also used to refer to a complete set of chromosomes in a species or an individual organism. So karyotypes describe the number of chromosomes and they look like and how they look under a light microscope. So attention is supposed to be paid to their length, the position of the centromeres, the binding pattern, any differences between the sex chromosomes and any other physical characteristics. The preparation and the study of this karyotype is part of this cytogenetics. A karyotype can also refer to a photographic illustrations of a strained metaphase spread in which the chromosomes are arranged in order of decreasing length. Many techniques for staining chromosomes have been developed, with widely used the GSMA staining technique, where each chromosome set can be seen to possess a distinctive pattern of alternating light and dark bands of variable widths. The use of these banding techniques allows certain identification of each chromosome as well as of the structural changes in the chromosomes. In human beings, the normal chromosome type is count is 46. An exact multiple of haploid is called euploid, whereas a chromosome number, okay, such as 3n, 4n is referred to as polyploid. So polyploid generally refers to a result into spontaneous abortion. Any number that is not an exact multiple of n is called aneuploid. So the chief cause of aneuploidy is non-disjunction of a homologous pair of chromosomes at the first mitotic division or failure of sister chromatids to separate during the second mitotic division. The latter may also occur during somatic cell division, leading to production of two aneuploid cells. Failure of pairing of homologous chromosomes followed by random assortment, anaphase lag, can also lead to aneuploidy. Okay, so we have monosomy and trisomy. So when disjunction occurs at the time of meiosis, gametes formed have either an extra chromosome or a less chromosome. Fertilization of such gametes by normal gametes would result into two types of zygotes: trisomy with an extra and monosomy with less than one. So monosomy involves an autosome in and is a monosomy that will be involving autosomes. These are body somes is incompatible with life, whereas trisomies of certain autosomes and monosomy involving sex chromosomes, this is compatible with life. Okay. So the term is used to describe the presence of two or more population of cells in the same individual. In the context of chromosome numbers, we have the post-zygomatic mitotic non-disjunction would result in the production of the trisomy and monosomic daughter cells, and the descendants of these cells will produce a mosaic. So mosaicism affecting sex chromosome is common, while autosome mosaic is not. Okay. So we have chromosomal structural chromosomal abnormalities in chromosomes. These normally result from chromosomal breakage with loss or rearrangement of the material. So we have cytogenic shorthand is used to select changes in the petite denotes the small arm of a chromosomes, and Q is the long arm. So each arm is then divided into numbers 1, 2, 3, and so on from a centromere outward. And within each region, the bands are numbered, are numerically ordered. So therefore, 2q34 indicates that chromosome 2, long arm region 3 and band 4. These patterns of chromosomal arrangement of the breakage are as follows. You could have the arm, which could be P, Q, so P short, Q long. Then you have the region 2, 1, 1, 2. We could have now the band and the subband, and they should be able to give you the exact location. So we could have translocation, whereby we have involving the transfer of this part of one chromosome to another in a reciprocal process where fragments are exchanged between two chromosomes. So in genetic shorthand, Translocation are indicated by T followed by the involved chromosomes in numeric number. For example, we have 46 XXT 5 or the Q31P14. So this will indicate a reciprocal translocation involving the long arm of chromosome number 2 at region number 3 and band 1 and the short arm of the chromosomes 5, region 1 and band 4. So when the complete broken pieces are exchanged, the resulting balanced reciprocal translocation is not harmful as the carrier has the normal number of chromosomes and the full complement of genetic material. However, during gametogenesis, the formation of unbalanced gametes result into abnormal zygotes. So translocation involving two acrocentric chromosomes is normally referred to as the centric fusion type or Robertsonian translocation where the breaks occur close to the centromere, affecting the short hands of both chromosomes. So transfer of segments leads to one very large chromosomes and the other extremely small one. So the short fragments are lost, leaving the carrier with 45 chromosomes. So the short arms of all acrocentric chromosomes carry highly redundant genes, for example, the ribosomal RNA genes. Therefore, the loss is compatible with the survival. However, gametogenesis could lead to abnormal offspring, like if you have the chromosomes. They result from when the centromere divides horizontally rather than vertically. So one of the two arms of the chromosomes is then lost and the remaining arm is duplicated, resulting in a chromosomes with short arms only or two long arms only. The most common isochromosome present in live births involves the long arm of the X chromosomes and is designated as XQI. Okay, so when fertilization occurs by a gamete that contains an abnormal X chromosome, there is monosomy for genes on XP and trisomy for the genes on XQ. So deletion will occur as a portion of a chromosomes where a single break may delete a terminal segment. So two interstitial breaks with a reunion of proximal and distal segments may result in loss of an intermediate segment. So the isolated fragment lacks a centromere and also never survives. Inversion do happen when the two interstitial breaks in chromosomes and the segment reunites after a complete turnaround. So a ring chromosome is a variant of a deletion after a loss of distal segments of each chromosomes and the arms unite to form a ring. So we have selected genetic disorders. And here we are looking at, first by looking at the cytogenic disorders involving autosomes, okay, involving the autosomes. So number one, we have to define what are these ones. So cytogenetic disorders involving autosomes are just genetic disorders caused by abnormality in the number or structure of the autosomal chromosomes. That is number 1 to 22 in humans. So these disorders can result from various types of chromosomal anomalies, including deletion, duplication, translocation, and inversions, what we have already looked at. So the first common condition is Down syndrome, also referred to as trisomy 21. So you find that individuals with this Down syndrome have an extra copy of chromosome 21, resulting in a total 3 copies, okay, instead of a typical 2, okay, of the typical 2. So features will include intellectual disability, characteristics of facial features, development delays, and increased risk of certain medication conditions such as heart defects and leukemia. Down syndrome is most common chromosomal disorder and occurs in about 1 in 700 life paths. It's majorly caused as a result of non-disjunction during meiosis, leading to the presence of an extra chromosome 21. So the overall prognosis of individuals with Down syndrome has improved as a result of better control of infection. So currently the median age at death is around 47 years. So most of those who survive into this middle age will develop histological, metabolic, and neurochemical changes of Alzheimer's disease. Many develop frank dementia, so the basis of this association is still being investigated. We hope the finding clues to this pathogenesis becomes more clear. Although the karyotype of Down syndrome has been known for decades, the molecular basis of this disease remains elusive. All right. So we have the mental retardation. We could have the low set of ears. Then we have abundant neck skin tissue. We have single palm crease. We have interstitial stenosis, hypotonia, gap between the first and second toes. Okay. We have the predisposition to leukemia, umbilical hernia, congenital heart defects, protruding tongue, and you have epicanthal folds and flat facial profile. All right. Okay. Number two condition is Edwards syndrome. This one is trisomy 18. Individuals with this syndrome have an extra copy of chromosomes 18, resulting into a total of 3 copies instead of 2. So patients will appear with severe intellectual disability, congenital heart defects, clenched hands, rocker bottom feet, and various other physical abnormalities. Edwards syndrome is rare and it occurs in around 1 per every 5,000 life paths. Most common cases result from non-disjunction during meiosis, leading to the presence of extra chromosome 18. And the guy could be presenting with low set of ears, heart-lung problems, overlapping fingers, club foot, okay, and decreased muscle tone. The third one is plateau syndrome, and this is trisomy 13. Individuals with this plateau syndrome have an extra copy on 13 and result into a total of 3 copies instead of 2 at chromosome number 13. Patients will present with severe intellectual disability, cleft lip and palate, eye abnormalities, and various physical deformities affecting organs or limbs. Plateau syndrome is rare. It occurs in around 1 in 10,000 life births. Most cases result from non-disjunction during meiosis, leading to presence of an extra chromosome 13. Okay, so we have the patient here. Okay, with a low set of ears, small head, and cleft palate, guys. Plateau syndrome. Okay, last one we have the Cry-Duchat syndrome. The Cry-Duchat syndrome is 5p syndrome, and it's caused by a deletion in the short arm of a chromosome 5. Okay, so we have patients who have intellectual disability, distinctive cat cry in infancy, which gives the syndrome its name, Cry-Duchat syndrome, have facial abnormalities and developmental delays. It occurs in around 1 in 20,000 to 50,000 live births. It's typically caused by spontaneous deletion of portion 5 of the chromosomes. We have cytogenetic disorders involving sex chromosomes. So these are genetic conditions caused by abnormalities in the number or structure of sex chromosomes, X and Y chromosomes. This disorder can affect the development of sexual characteristics and could lead to a variety of physical and sometimes intellectual and behavioral abnormalities. The first one being the Turner syndrome, which is 45X. You find that individuals with this syndrome have a single X chromosomes. So they tend to have 45 chromosomes instead of 46 chromosomes. Okay? They'll be having short stature, lack of ovarian development leading to infertility. They'll have webbed neck, low hairline at the back of the hair, and certain heart and kidney abnormalities. Can be treated using the hormonal therapy, that is the estrogen replacement, just to induce puberty and promote growth. You can also have assisted reproductive technologies may be used for this fertility. The second condition, which is these cytogenic disorders involving sex chromosome, is the Klinefelter syndrome. Okay, so here these individuals have an extra X chromosomes and therefore now have 48 chromosomes instead of they have 37 chromosomes, 47 instead of 46. So they have an extra X chromosome. So these patients will present with reduced fertility. They could be having tall stature and gynecomastia, okay, enlarged breast, small testes, potential learning difficulties. We could have hormonal replacement therapy with testosterone just to promote physical and sexual development. Also, education and psychological support to address any learning or social challenges is very important. The third condition is triple X syndrome, where now these patients have an extra X chromosomes, making it 47. They will also present with tall texture like the Klinefelter syndrome. They'll have delayed speech and language development, sometimes learning difficulties or emotional and behavioral challenges. Most individuals have normal fertility. Treatment will be supportive therapy such as speech and language if needed. The psychological support for emotional and social challenges is vital. The last one, you have the XYY syndrome, where someone has an extra Y chromosome, making them to have 47 with XYY. So they'll have also tall stature, sometimes delayed speech and language and behavioral changes. So most individuals have normal fertility. Supportive therapies for speech and language is very important. We also have psychological support for behavioral and social challenges. Next, we have the single gene disorders with atypical patterns of inheritance. So these are the three groups of disease resulting from mutations affecting single genes that do not follow the Mendelian rules of inheritance. Okay, so this could include diseases caused by triplet repeat mutations, mutation in mitochondrial genes, and genomic imprinting. So when you look at triplets, genetic repeat mutations. These are type of genetic mutation where the sequence of three nucleotides, e.g. the CAG, the CTG, CGG, is repeated multiple times in a gene. These mutations can lead to various genetic disorders, including the Huntington's disease, Fragile X syndrome, and myotonic dystrophy. The severity of this disease often correlates with the number of repeats. The more the repeats typically result in earlier onset and more severe symptoms. Triplet repeat mutation can expand in future generation, leading to anticipations where the disorder becomes more severe and presents at an earlier age in successive generations. So mutations in mitochondrial genes, you find that these mitochondrial genes are located in the mitochondria, and the mitochondria is the energy producing organelles in cells. So unlike the nuclear DNA, which is normally inherited from both parents, mitochondrial DNA, which is abbreviated as mtDNA, is inherited exclusively from the mother. So mutations in mitochondrial genes can cause a variety of mitochondrial disorders, which can affect the tissues and organs which with high energy demands, and these organs that require high or have high energy demands include the brain, muscles, and the heart. The symptoms and severity of mitochondrial disorders can vary widely, and there is currently no cure, although research into potential treatment is ongoing. going. So we could differentiate between triple repeat mutations and vis-a-vis the mutations in mitochondrial genes. We find that in terms of location, triplet repeat mutations occur within nuclear DNA, okay, chromosomes in the cell nucleus, whereas mitochondrial genes occur, mutations occur within mitochondrial DNA found in the mitochondria. The type of mutation found in the triplet repeat mutations involves repetition of sequence of 3 nucleotides, while for the mutations in the mitochondrial genes can involve various types of mutation. It could be point mutations, deletions, insertions within mitochondrial genes. When you look at the inheritance patterns, triple repeat mutation can be inherited from one or both parents, often displaying anticipation, that's increased severity or earlier onset in successive generations. While the mutations in mitochondrial genes are inherited exclusively from the mother, as the mitochondrial DNA is maternally inherited. When you look at associated disorders, triple repeat mutation can lead to diseases such as Huntington's disease, Fragile X syndrome, and mitochondrial dystrophy. While the mutations in the mitochondrial genes can cause mitochondrial disorders affecting organs with high energy demands, leading to various conditions and diseases. For the treatment approaches, triple repeat mutation, we have research that is undergoing for potential gene therapies, but currently there is limited treatment to slow this progression of these symptoms. For the mutations in mitochondrial genes, management involves supportive care, symptom-specific treatment, therapies to address complications and improve the quality of life. So, for the genomic imprinting, okay, genomic imprinting is an epigenetic phenomena where specific genes are expressed in a parent of origin dependent manner. So this means that the expression of certain genes depend on whether they are inherited from the mother or the father. So during imprinting, one allele of the gene is marked or imprinted in such a way that it is either activated or silenced. So imprinted genes play crucial roles in fetal development and growth. So disruptions in normal imprinting processes can lead to genetic disorders such as the Prader-Willi syndrome and the Engelmann syndrome, where genes on chromosome number 15 are affected by imprinting errors. Okay? So all human beings normally inherit 2 copies of each gene carried on homologous maternal and paternal chromosomes. It is usually been assumed that there is no difference between normal homologous genes derived from the mother or the mother. However, it has been established that in some genes, functional differences exist between paternal and maternal genes. So this occur from epigenetic a process called genomic imprinting, where certain genes are differentially inactivated during gametogenesis. Thus, maternal imprinting refers to transcriptional silencing of maternal alleles, while paternal imprinting implies that the paternal allele is inactivated. Imprinting occurs in ovum or sperm and is then stably transmitted to all somatic cells derived from the zygote. So genetic imprinting can be illustrated using 2 uncommon genetic disorders which we have already listed, the Prader-Willi syndrome and the Angelman syndrome. So, when you look at the Prader-Willi syndrome, this is a rare genetic disorder characterized by various physical, mental, and behavioral symptoms. It's caused by loss of functional specific genes on chromosome number 15, which is normally inherited from the father. As a result, the patient will present with poor, the weak muscle tone or hypotonia, where babies exhibit weak muscle tone, leading to difficulties in feeding and motor development. Number 2, the babies will also present with hyperphagia, which is excessive hunger, and this is one of the hallmark signs of this Prader-Willi syndrome, where patients will present with insatiable appetite, which can lead to obesity if not controlled. So these patients, they will lack sensation of feeling full, leading to constant hunger. Patient can also present with intellectual disability, where they are going to have mild to moderate intellectual disabilities or behavioral and psychiatric issues, and this could include temper tantrums, obsessive compulsive behavior, and mood swings. Lastly, the patient could present with hormonal imbalances, for example, the growth hormone deficiency, delayed puberty, or underdeveloped sex organ. So management involves multidisciplinary approach, including behavioral therapy, dietary management to control calorie intake, growth hormone therapy, and support for family dealing with these challenges associated with the as this syndrome. While the Angelman syndrome is a rare genetic disorder caused by abnormalities in the same region of the chromosome 15 that causes the Prader-Willi syndrome. However, in the case of this Angelman, the genetic abnormality will occur on the maternal chromosome 15. So the patients will present with developmental delays, will have seizures. Some have been accused of having a happy demeanor. Okay, so they are usually happy and excited demeanor, often smiling and laughing frequently. But they could also be having also movement and balance issues, absence of speech and sleep disturbances. Early intervention and supportive treatment are of essence for these people with Angelman syndrome. In summary, guys, we can be able to differentiate between Prader-Willi syndrome and Angelman syndrome in terms of genetic causes, feeding behavior, speech development, motor skills, and lastly, behavioral traits. If we look at the genetic cause, the Prader-Willi syndrome is caused by deletion or inactivation of genes on the paternal chromosome number 5, while the Angelman syndrome is caused by deletion or inactivation of genes on the maternal chromosomal number 15, that is. Okay? In terms of the feeding behavior, Prader-Willi syndrome, patients will present with hypophagia, while Angelman syndrome, patients will have normal appetite with no issues with constant hunger. For the Prader-Willi syndrome patients, they will be presenting with delayed speech development and language skills are limited. While the Angelman syndrome, the patients will be having no speech. Okay, most individuals do not develop meaningful speech. For the motor skills, Prader-Willi syndrome patients will have weak muscle tone, hypotonia, and often present motor developmental delays. While the Angelman syndrome, the patients are going to present with motor coordination problems, balance issues, and jerky movements. Lastly, for the behavioral traits, for the Prader-Willi syndrome, obsessive compulsive behavior or temper tantrums are very common, while for the Angelman syndrome, they are very happy demeanor, frequent smiling, laughing, and often exhibiting a joyful disposition. And that's the difference. Finally, we have the Prader-Willi syndrome is brother, so it is related to the males. Then Angels is related to the maternal chromosome number 15. Okay, correct, guys. So these are some of the review questions, guys. Guys, you should be able at least to give 3 examples of diseases with multifactorial inheritance as an underlying factor. Okay, okay, guys, do you still remember that? Like hypertension, yes, like diabetes mellitus. Okay, guys, you should be able to give the 3 groups of diseases that result from mutations affecting single gene that do not follow the Mendelian rule of inheritance, guys. Okay? Then give an example of this disorder in each case. You need to give genetic variations in hemophilia and sickle cell. You need to differentiate between terms polyploidy and uniploidy as applied in cytogenetics. You also need to state clinical features of a child having Down syndrome, and lastly, state the differences between Prader-Willi syndrome, and Angelman syndrome. Guys, I hope this presentation has been of help to you, okay, and has been informative. I think until next time, please take care of yourself. Bye bye.